Hospital-acquired pressure injuries (HAPI) are considered by CMS as a never event because a. They are extremely rare in all patient populations. b. They are considered reasonably preventable with appropriate evidence-based care. c. They only occur in negligent facilities. d. They are more expensive than other complications. The correct answer is, they are considered reasonably preventable with appropriate evidence-based care. CMS designated stage Roman III, stage Roman IV, and unstageable pressure injuries as hospital-acquired conditions (HACs) never events because they are considered preventable with appropriate evidence-based care. Since 2008, CMS does not reimburse hospitals for additional costs associated with HAPI that were not documented on admission PVOA present on admission. Which clinical situation warrants use of a Group 2 support surface-powered air mattress or low air loss mattress? A. A fully mobile patient with intact skin at low risk for pressure injury. B. A patient with an existing stage 3 or 4 pressure injury or multiple stage 2 injuries unresponsive to a Group 1 surface. C. Any patient in a long-term care facility regardless of risk status. D. Only for patients post-operatively following orthopedic surgery. The correct answer is, a patient with an existing stage 3 or 4 pressure injury or multiple stage 2 injuries unresponsive to a Group 1 surface. Group 2 support surfaces powered alternating pressure, low air loss, or air fluidized mattresses are indicated for patients with existing stage 3 or 4 pressure injuries, multiple stage 2 injuries, inability to be positioned off an existing injury, and failed Group 1 surfaces. Medicare covers Group 2 surfaces when documentation supports medical necessity meeting these criteria. A diabetic patient with peripheral neuropathy performs monofilament testing. Loss of sensation to which monofilament indicates loss of protective sensation. A. 1 gram Semmes-Weinstein monofilament. B. 5.0710 gram Semmes-Weinstein monofilament. C. 6.65 gram monofilament. D. 2 gram monofilament. The correct answer is 5.0710 gram Semmes-Weinstein monofilament. The 5.0710 gram Semmes-Weinstein monofilament applies 10 grams of force and tests for protective sensation. Inability to feel the 10 gram monofilament at standard testing sites plantar surface of the hallux and metatarsal heads indicates loss of protective sensation, the primary risk factor for neuropathic foot ulceration. Normal sensation is feeling the monofilament without visual cues. A visiting nurse makes a wound care documentation error and realizes it several days later. The correct action is A. Add an addendum noting the error and providing the correct information with date, time, and signature. B. Return to the original note and change it without notation. C. Leave the error uncorrected to avoid drawing attention to it. D. File an incident report without correcting the record. The correct answer is, add an addendum noting the error and providing the correct information, with date, time, and signature. Correcting a previously made documentation error, add a clearly labeled addendum, not a backdated entry with current date and time, reference to original entry, addendum to visit note dated date, correction of the error, reason for correction, clinician signature, and credentials. Do not alter original entries retroactively. This constitutes falsification. Accountable care organizations ACOs and wound care are related because ACOs, A. Are only responsible for physician office wound care. B. Share financial risk for total cost of care, creating incentives to prevent HAPI, reduce readmissions, and optimize wound management across the care continuum. C. Are not involved in wound care quality. D. Only focus on cardiac and oncology care. The correct answer is share financial risk for total cost of care, creating incentives to prevent HAPI, reduce readmissions, and optimize wound management across the care continuum. ACOs, provider groups sharing financial risk under Medicare, have strong incentives to prevent costly wound complications. HAPI increase loss and costs, poorly managed wounds cause readmissions, and healing failures increase total cost of care. ACOs invest in wound care programs, transitional care, and post-discharge wound management to reduce total spending. An enterocutaneous fistula is identified during wound reassessment when the wound drainage becomes a. more serous and clear, b. biocolored, feculent, or contains obvious intestinal contents, c. thick and purulent only, d. bloody sanguineous. The correct answer is biocolored, feculent, or contains obvious intestinal contents. Enterocutaneous fistula bowel to skin abnormal connection produces drainage that contains intestinal contents bile-stained, feculent stool-like, or clearly enteric. This is a serious complication requiring specialized wound management, fistula pouching containment, nutritional support, and often surgical intervention. A patient with a venous leg ulcer needs education about compression therapy. Which statement would indicate the patient misunderstands the teaching? A. I should elevate my legs above my heart when resting. B. I should remove my compression stockings at night before sleeping. C. I should walk regularly to help my leg veins pump blood back to my heart. D. I should put on my compression stocking before getting out of bed in the morning. The correct answer is, I should remove my compression stockings at night before sleeping. Removing compression stockings at night is correct practice. They are generally not worn during sleep when the leg is elevated. The misunderstanding would be, I can remove my stockings whenever my legs feel tight, or I don't need to wear them if I'm not in pain. Applying before rising and walking regularly are correct. This question requires careful reading. Removing at night is correct. What is the most important characteristic of a successful wound care quality improvement initiative? A. Using only the most expensive wound care products available. B. A systematic data-driven approach with measurable goals, stakeholder engagement, evidence-based interventions, and sustained monitoring. C. Implementing all changes simultaneously across the facility. D. Limiting the initiative to wound care specialists only. The correct answer is a systematic data-driven approach with measurable goals, stakeholder engagement, evidence-based interventions, and sustained monitoring. Successful QI initiatives share 1. Clear, measurable SMART goals, 2. Baseline data collection, 3. Evidence-based interventions, 4. Engagement of frontline staff and leadership, 5. Rapid cycle testing PDSA, 6. Transparent data sharing, 7. Sustained monitoring with feedback loops, and 8. Celebration of improvements to reinforce the change. The scope of practice for a physical therapist (PT) in wound care typically includes a. Prescribing systemic antibiotics for wound infections. B. Wound debridement within state practice acts, physical modalities, exercise for healing, and mobility interventions for offloading. C. Independent wound staging and MDS documentation. D. Ordering wound care dressings and NPWT. The correct answer is wound debridement within state practice acts, physical modalities, exercise for healing, and mobility interventions for offloading. PT scope in wound care. Wound debridement allowed in most states under PT practice acts: sharp, enzymatic, mechanical, physical modalities, electrical stimulation, ultrasound, whirlpool, therapeutic exercise to improve perfusion and wound healing, gait training, and offloading device fitting. PTs cannot prescribe medications or order NPWT independently. Under CMS Hospital-Acquired Conditions HAC policy, what is the financial impact of a stage 3 or 4 pressure injury acquired during a hospital stay? A. Hospitals receive a bonus payment for reporting the HAC. B. Hospitals receive a 1 bonus for early reporting. C. Medicare does not reimburse hospitals for the additional care costs associated with the HAC. D. The patient is responsible for all additional costs associated with the HAC. The correct answer is Medicare does not reimburse hospitals for the additional care costs associated with the HAC. Under CMS HAC policy effective 2008, Medicare does not pay for the additional costs of treating stage 3 and 4 pressure injuries and other conditions that develop during a hospital stay, as they are considered preventable. This creates a strong financial incentive for hospitals to invest in pressure injury prevention programs. Hospitals may also face a 1 reduction in inpatient payments under the HAC reduction program. A pressure injury covered with stable, dry, adherent, intact HR without erythema or fluctuance should be staged as A. Stage Roman 3, B. Stage Roman 4, C. Unstageable, D. Deep tissue pressure injury. The correct answer is unstageable. When the wound bed is obscured by slough or eschar that cannot be removed to visualize the wound base, the injury is classified as unstageable. Stable eschar on heel wounds is an exception. It may be left intact as a natural cover per NPUEP guidelines. Which phase of wound healing is primarily responsible for increasing wound tensile strength? A. Hemostasis. B. Inflammatory phase. C. Proliferative phase. D. Maturation remodeling phase. The correct answer is maturation remodeling phase. The maturation remodeling phase weeks to 2 years involves reorganization of type Roman 3 collagen to stronger type I collagen, increasing tensile strength from approximately 25 at wound closure to about 80 of original tissue strength. A healed wound never fully regains 100 tensile strength, which is why recurrence prevention is critical. A wound that was previously classified as stage Roman 3 pressure injury that shows improvement and is now covered with granulation tissue should be documented as A. Stage Roman 2 pressure injury, B. Healing stage Roman 3 pressure injury, C. Stage I pressure injury, D. Reverse staged stage Roman 3. The correct answer is healing stage Roman 3 pressure injury. Pressure injuries should not be reverse staged, i.e. downgraded, as they heal. A stage Roman 3 that improves is documented as a healing stage Roman 3 pressure injury. The NPUEP guidelines specify that staging reflects the maximum depth of tissue damage observed at its worst, not current status. When assessing for tunneling, the clinician uses a sterile cotton-tipped applicator. The applicator inserts 3 cm at the 12 o'clock position. This finding is documented as A. Undermining 3 cm at 12 o'clock, B. Tunneling 3 cm at 12 o'clock, C. Sinus tract 3 cm, superior aspect, D. Depth extension 3 cm superior. The correct answer is tunneling 3 cm at 12 o'clock. Tunneling is a narrow channel extending from the wound base in one direction, documented by the depth cm and clock face location. Undermining involves a broader pocket under the wound edges. Using 12 o'clock equals toward the head is the standard notation when the patient is supine. Near-miss incident reporting in wound care is important because A. Near misses do not require reporting since no harm occurred. B. Near misses reveal system vulnerabilities that, if corrected, prevent actual adverse events. They represent learning opportunities without patient harm. C. Near misses only need to be reported if the patient is aware. D. Near-miss reporting is required only by accrediting bodies, not internally. The correct answer is near misses reveal system vulnerabilities that, if corrected, prevent actual adverse events. They represent learning opportunities without patient harm. Near-miss close call reporting is a cornerstone of patient safety culture. Near-miss is, for example, almost giving wrong wound care product. Almost missing a happy risk assessment expose the same system failures that lead to actual adverse events without the harm. High reliability organizations encourage near-miss reporting and analyze them as rigorously as actual events. A wound presents with yellow, stringy tissue that must be removed before healing can occur. This tissue is best described as A. Granulation tissue, B. Slough, C. Eschar, D. Epithelial tissue. The correct answer is slough. Slough is devitalized, non-viable tissue that appears yellow, tan, gray, or green. It is typically moist and stringy or mucinous in texture. Slough must be debrided because it harbors bacteria and prevents epithelial migration. Granulation tissue is healthy red-pink, eschar is dry black-brown necrosis, and epithelial tissue appears as a thin silvery pink layer at wound edges. A 78-year-old patient with a sacral wound demonstrates periwound skin warmth, erythema extending 2 cm beyond the wound edge, and increased serous drainage. The patient has a low-grade fever. These findings most suggest A. Normal inflammatory healing phase, B. Superficial wound colonization, C. Wound infection requiring intervention, D. Allergic contact dermatitis. The correct answer is wound infection requiring intervention. Classic signs of local wound infection include increased pain, peri-wound erythema 2 cm, warmth, edema, purulent exudate, delayed healing, and odor. Systemic signs fever, elevated WBC indicate spreading infection. These findings warrant wound culture and possible antibiotic therapy. A patient's stage Roman 3 sacral wound was 8 cm 6 cm 2 weeks ago. Today it measures 6 cm 5 cm. What percentage of wound area reduction has occurred? A. 18.75. B. 37.5. C. 25. D. 50. The correct answer is 37.5. Initial area equals 8.6 equals 48 cm. Current area equals 6.5 equals 30 cm. Reduction equals 48 30 48 100 equals 37.5. This exceeds the 2030 threshold, indicating an adequate healing response. The treatment plan should continue with ongoing reassessment. The primary goal of wound irrigation pressure should be between A. 14 psi gentle bulb syringe, B. 415 psi effective debris removal without tissue damage, C. 2030 psi maximum debridement pressure, D. Over 30 psi for surgical level cleansing. The correct answer is 415 psi effective debris removal without tissue damage. Evidence-based wound irrigation pressure of 415 psi effectively removes surface debris, bacteria, and exudate without driving organisms deeper or damaging tissue. A 35 ml syringe with a 19-gauge angiocath delivers approximately 8 psi. Pressures 4 psi are ineffective. 15 psi may drive bacteria deeper and traumatize tissue. When assessing readiness to learn before wound care teaching, the wound care nurse should evaluate which patient factor: A. Patient's employment status, B. Patient's current physical state, pain level, emotional readiness, and motivation to learn, C. Patient's past compliance with other treatments, D. Patient's insurance coverage. The correct answer is patient's current physical state, pain level, emotional readiness, and motivation to learn. Readiness to learn assessment includes physical readiness, pain controlled, fatigue managed, sensory abilities intact, emotional readiness, patient is not in denial, not acutely grieving, motivated, experiential readiness, prior knowledge, relevant experience, and knowledge readiness, current understanding of condition. Proceeding without assessing readiness leads to ineffective education. When implementing a new electronic skin assessment tool in an EHR for pressure injury surveillance, the key validation step is A. Having IT staff approve the tool design, B. Piloting the tool on a small unit with end users to test usability, accuracy, workflow integration, and inter-rater reliability before full deployment, C. Getting physician approval without nursing input, D. Deploying facility-wide simultaneously without testing. The correct answer is piloting the tool on a small unit with end users to test usability, accuracy, workflow integration, and inter-rater reliability before full deployment. New clinical tools should be piloted using PDSA methodology, small-scale implementation, evaluation of usability and user acceptance, clinical accuracy, does it capture data correctly, workflow integration, time burden, and inter-rater reliability, do different nurses get the same results? Problems identified in pilot prevent facility-wide failures. Value-based purchasing in wound care means that reimbursement is tied to A. Volume of wound care services provided, B. Quality outcomes and cost-effectiveness of care rather than simply the number of procedures performed, C. The number of wound care products used, D. Physician specialty certification. The correct answer is quality outcomes and cost-effectiveness of care rather than simply the number of procedures performed. Value-based purchasing (VBP) shifts reimbursement from volume-based to value-based models. Payers reimburse for quality outcomes, wound healing rates, happy prevention, readmission rates, patient satisfaction, and cost-effectiveness. Facilities with better wound care outcomes and lower happy rates earn higher reimbursement. Wound care documentation in EHR must support which reimbursement requirement under Medicare for home health services? A. Documentation of physician specialty. B. Skilled care necessity documentation that wound care requires the skills of a licensed nurse and cannot safely be performed by a non-skilled caregiver. C. Number of wound photographs taken. D. Family's ability to perform wound care. The correct answer is skilled care necessity documentation that wound care requires the skills of a licensed nurse and cannot safely be performed by a non-skilled caregiver. Medicare home health reimbursement requires documentation of skilled care necessity. The wound care requires clinical observation, assessment, and skilled nursing judgment, not just mechanical task performance. Documentation must demonstrate why skilled nursing visits are needed, for example, wound deterioration assessment, infection signs, wound technique complexity. Which BMI range is associated with increased pressure injury risk in hospitalized patients? A. BMI 18.5 to 4.9 normal weight. B. BMI 18.5 underweight and BMI 30 obese. C. BMI 2529.9 overweight. D. BMI is not associated with pressure injury risk. The correct answer is BMI 18.5 underweight and BMI 30 obese. Both extremes of BMI increase happy risk. Underweight BMI 18.5 equals inadequate subcutaneous tissue padding, reduced protein reserves, skin fragility. Obese BMI 30 equals skin fold moisture and friction, difficulty repositioning, limited nursing assistance, inadequate equipment, impaired perfusion from pressure, and comorbidities. Both populations require enhanced prevention strategies. A patient with chronic obstructive pulmonary disease copped on long-term corticosteroids has multiple risk factors for wound development. Which factor related to corticosteroid use is most relevant to skin fragility? A. Decreased appetite. B. Corticosteroid-induced skin atrophy, thinning, and impaired inflammatory response. C. Decreased mobility. D. Increased sleeping hours. The correct answer is corticosteroid-induced skin atrophy, thinning, and impaired inflammatory response. Long-term corticosteroids cause skin atrophy, thinning, dermis, reduced collagen, easy bruising and skin tears, impaired inflammatory wound healing, increased infection risk, and hypoalbuminemia contributing to edema. Corticosteroid skin atrophy dramatically increases vulnerability to skin tears, pressure injury, and delayed healing. The stratum lucidum is found only in which anatomical locations? A. The scalp and back. B. The palms of the hands and soles of the feet. C. The face and neck. D. The inner forearm and abdomen. The correct answer is the palms of the hands and soles of the feet. The stratum lucidum is a thin, clear layer of dead cells located between the stratum corneum and stratum granulosum. It is present only in thick skin, the palms and soles, where additional protection against friction and pressure is needed. The two most important outcome measures for venous leg ulcer treatment efficacy are A. Patient pain level and dressing wear time. B. Wound closure rate and time to healing. C. Exudate amount and odor control. D. Patient quality of life and cost per dressing. The correct answer is wound closure rate and time to healing. The primary outcomes for VLU treatment efficacy are wound closure rate, percentage of wounds healed within a defined period, and time to healing, weeks, months to complete wound closure. Secondary outcomes include recurrence rate, quality of life, and cost effectiveness. These are the endpoints used in clinical trials. Which patient education technique is considered most effective for verifying wound care understanding? A. Providing detailed written handouts for the patient to review at home. B. Using the teach-back method, where the patient explains the information back in their own words. C. Having the patient sign a consent form confirming they received instructions. D. Showing an educational video and asking if the patient has any questions. The correct answer is using the teach-back method, where the patient explains the information back in their own words. The teach-back method, also called closing the loop, is an evidence-based technique where the clinician asks patients to re-explain instructions in their own words. This verifies actual comprehension rather than just information receipt. It is recommended by the Joint Commission and is particularly important for wound care instructions, which patients must perform independently at home. The teach-back method in patient education is best described as a. Reviewing written handouts with patients multiple times, b. Asking the patient or caregiver to explain or demonstrate the information back in their own words, c. Playing educational videos repeatedly, d. Having a family member attend all teaching sessions. The correct answer is asking the patient or caregiver to explain or demonstrate the information back in their own words. The teach-back method verifies patient comprehension by asking the patient to explain the information just taught in their own words or demonstrate a skill. It identifies knowledge gaps immediately so the clinician can reteach. It is not a test of intelligence but a test of the clinician's teaching effectiveness. Which population is at highest risk for developing a medical device-related pressure injury (MDRPI)? A. Ambulatory adults in outpatient settings. B. Critically ill ICU patients with multiple monitoring support devices. C. Patients with stage I pressure injuries. D. Post-surgical patients with uncomplicated recoveries. The correct answer is critically ill ICU patients with multiple monitoring support devices. ICU patients have the highest MDRPI risk due to multiple simultaneous devices ETT, CPAP, NG tube, cervical collar, monitoring leads, Roman 4 boards, SCD sleeves, hemodynamic instability limiting repositioning, sedation preventing self-repositioning, edema reducing tissue tolerance, and critical illness impairing skin integrity. Prevention requires daily skin inspection under around all devices. How many did you get right? Let us know in the comments, and tell us what topics you want us to cover next. Want to practice more? Download the app and get hundreds of free practice questions with detailed explanations.